Hello, Clinic Review families. Dr. Sharon with Clinic Reviews. Today, we're going to talk about treating rhythms. I have done videos in the past where I help you learn how to interpret rhythms. I'll probably do some again in the future. But if you're looking for interpretation of rhythms, go to the cardiac playlist, and you're going to see a lot of videos there about interpreting rhythms. Today, I'm going to talk about treating rhythms. So let's go ahead and get started. Hello, Clinic Review family. I hope you're doing well. It's almost summertime here as I'm making this video. The weather is beautiful. If you are watching this during the winter, I'm so sorry because right now, as I'm making this, it's summer and it's wonderful. All right. You know, this channel is part of the greater Clinic Review organization. Clinic Reviews was started by Mark Klimek over 40 years ago. He is the GOAT of Nclex review. You can go to clinicreviews.com and get our online on-demand review. It is 21 plus hours of Nclex prep. And you can also see our streaming service and you can do small group tutoring. I do some of the small group tutoring. We do next gen case studies and standalone questions as part of the small group tutoring. So let's go ahead and get started. We are going to be talking about treating rhythms today. There's no visual rhythms here. It's going to tell you what the rhythm is. You're going to have to know what to do. And there are going to be some rhythms on here that are not on Nclex, but a lot of these rhythms are going to be on Nclex. A 72-year-old patient in atrial fibrillation with rapid ventricular response complains of dizziness and shortness of breath. Which nursing action is most appropriate? Prepare for synchronized cardioversion. Administer IV amiodarone as ordered. Increase the IV infusion rate of normal saline. Apply supplemental oxygen and reassess vital signs. So AFib with a rapid ventricular response. So how do we treat AFib? Well, we want to get the rate down and we want to try to convert it to sinus rhythm if we can. So how do we do that? The drugs of choice for slowing it down and converting it to sinus rhythm is either diltiazem, cardizem, or amiodarone. So that's what we're going to do. C and D don't really apply in this situation. We could do synchronized cardioversion, but that's not the first thing we do. We try medications first before we cardiovert them. A patient on telemetry develops sustained monomorphic ventricular tachycardia, but remains alert and his blood pressure is 100/60. What is the nurse's priority? Call a code blue, administer IV procainamide per protocol, prepare for immediate unsynchronized defibrillation, give sublingual nitroglycerin. So VTAC, with VTAC, you need to know if there's a pulse or not. This patient clearly has a pulse. He wouldn't be alert. He wouldn't have a blood pressure if he didn't have a pulse. So this is VTAC with a pulse. You can have VTAC with no pulse. VTAC with no pulse, you treat just like you treat ventricular fibrillation. VTAC with no pulse, you start CPR and you defib. But VTAC with a pulse, you're going to either treat with a medication or you're going to treat with synchronized cardioversion. And we don't have an option to synchronize cardiovert here. And we don't call a code blue when they have a pulse. So the other option is amiodarone or lidocaine, and procainamide is the lidocaine option. And I wanted to put this here in case you are not familiar with procainamide. This is sort of an old school medication. Before we had amiodarone, we used it all the time. It's still available. It's still possible to use that. Okay. Now, if you don't know what monomorphic means, mono means one, morphic basically means the place it starts. Where is it starting? Monomorphic. So it's starting from one place. So the electrical impulse is starting in the ventricles and it's only starting from one place, which means it has a nice pattern. And it's usually a V pattern. That's usually what it looks like, especially if they have a pulse. It's going to look like a nice V pattern. So you do need to get them out of this because it's not a sustainable long-term rhythm, but you've got a little bit of time. They have a pulse. It's monomorphic. If it becomes polymorphic, that's when you start seeing really wide U-looking rhythm as opposed to a V-looking rhythm. So that's sort of the difference between polymorphic and monomorphic. A 65-year-old patient's telemetry shows sinus bradycardia at 38 beats per minute. He's pale, diaphoretic, and reports chest pain. Which action should the nurse take first? Atropine, IV push, 12-lead ECG, increase IV fluid rate, assess for medication history. Well, we have symptomatic bradycardia. If he was asymptomatic, I could probably do some other things, right? But he's symptomatic. We have to treat the symptoms, diaphoretic and chest pain. The best way to treat that is to get the heart rate back up. So the treatment, the drug of choice for symptomatic bradycardia is atropine. Okay. So we've learned about procainamide. Procainamide can be used for ventricular dysrhythmias. Amiodarone and cardizem can be used for atrial dysrhythmias, and atropine is used for symptomatic bradycardia. On review, a patient's ECG shows PR intervals of 0.28 seconds, but is otherwise asymptomatic. The nurse should prepare for pacemaker insertion, assess medication list for AV node blockers, call the healthcare provider immediately, document, and continue routine monitoring. So when you have a regular rhythm, the only thing that's wrong is a long PR interval. That's called a first-degree heart block. Everything's fine. You have a normal P wave, you have a normal QRS, you have a normal T. The rate is fine, right? It says otherwise asymptomatic. So that means, the P wave's normal, the QRS is normal, the T wave's normal, the heart rate's normal, everything else is normal. Just a long PR interval. So that's the distance between the P wave and the QRS. So normally the distance between the P and the QRS should be 0.12 to 0.20. That's fractions of a second, 12 100ths of a second to 20 100ths of a second. If it takes longer than that, now it's taking 28 100ths of a second. You say, well, it's taking longer to get from the P to the QRS or from the SA to the AV. If it's asymptomatic, honestly, y'all, we do nothing about it. We see first-degree heart blocks fairly regularly in the hospital. We do absolutely nothing about that. So you're just going to document and continue to monitor. A patient exhibits progressive PR prolongation until a dropped beat, but remains asymptomatic. That's a key word, asymptomatic. The nurse's best action is to prepare for transcutaneous pacing, monitor and continue to observe, administer IV dopamine, increase oxygen therapy. Well, longer drop, then you've got the Wenke Bach. Longer drop, then you've got the Wenke Bach. So a progressive PR prolongation. So you have a normal PR, and then you have a longer PR, and then you have a longer PR, and then a longer PR, and then you drop the QRS. And then you go back to a normal PR, and then a longer, and then a longer, and a longer, and then you drop the QRS. So like every fourth or fifth beat, you drop your QRS as your PR lengthens. That's called a second-degree heart block Mobitz 1, also known as Wenke Bach. So that's why I say longer drop. Then you've got the Wenke Bach. It's a Mobitz 1, second-degree Mobitz 1. And if they're asymptomatic, we don't usually do anything about it. If they were symptomatic, we would consider, we could use atropine to speed up the heart rate. That could be kind of an initial treatment. And then we could consider a pacemaker. That's something to consider. But this person has Wenke Bach and no symptoms. So oxygen doesn't do anything for it. Dopamine doesn't do anything for it. So are we going to prepare for transcutaneous pacing, which is bedside pacing, or are we going to monitor and continue to observe? Now you may say, well, I've had patients in Wenke Bach and I called the doctor. Well, calling the doctor is not an option here. Okay. So remember, the right answer is the right answer because of the other answers. And prepare for transcutaneous pacing is really aggressive when you have an asymptomatic patient. So in this case, we're going to pick the answer that shows we know when they're asymptomatic. We're going to continue to monitor them, monitor their heart, continue to observe. If they become symptomatic or it gets worse, we can call the doctor. Now, if it said call the doctor here, I'd have a really hard time answering this question because honestly, I probably would know. It wouldn't be an emergency. I'd probably send them a message, something like that. Just say, hey, just let you know. They're in a Mobitz 1. They're asymptomatic. I just wanted you to know. Or I'd look to see if the cardiologist wrote a note about it. Like in real life, that's what I would do. But on a test, when these are your options, you're going to monitor and continue to observe. A 68-year-old with a Mobitz 2, which is a second-degree type 2, Mobitz 2 AV block, has a heart rate of 35 and has become lightheaded. What should the nurse do first? Administer IV atropine, prepare for immediate permanent pacemaker, assess electrolyte levels, admit to telemetry, and observe. So we may have to do pacemaking. We may have to. A Mobitz 2 is different from a Mobitz 1 in that it has a pattern of dropped QRSs. So it doesn't get longer drop. It may drop like every other QRS. It may drop every third QRS. It may drop every fourth QRS. But it's just a regular pattern of dropping QRSs as opposed to getting longer drop. And a Mobitz 2, in this case, they have a Mobitz 2 and it's symptomatic. In this case, it's symptomatic bradycardia. It's caused by a Mobitz 2. It's not a sinus brady. It's a Mobitz 2. But will atropine help? Yes, it will. So atropine is what we would do first. Then according to protocol, right? So then we'd let the doctor know. They may come up and say, hopefully the atropine speeds it up a little bit. It's not a long-term solution. It's a short-term solution. It immediately gets the heart rate up so that hopefully they'll be more stable and they won't be lightheaded. Then the doctor probably will assess them and decide, do they need a pacemaker or are we going to do something else? A patient in complete heart block is hypotensive and confused. The priority nursing action is transcutaneous pacing, IV diltiazem, position Trendelenburg, or IV lidocaine. So I don't think I even taught about complete heart block. I might have. I know I have some heart block lectures, but you absolutely don't have to know complete heart block for Nclex. What you should know about complete heart block. Complete heart block means there's no relationship, there's no communication between the SA and the AV node. So if I gave atropine to speed up the AV node or the SA node, it wouldn't do anything for the heart block. So this person has a complete blockage of electrical communication between the top of the heart and the bottom of the heart. No communication. And that's not a sustainable rhythm. Eventually, it's going to go bad. The only treatment for a complete heart block is transcutaneous pacing or permanent pacing, right? Pacing is the only treatment for a complete heart block. And they are symptomatic with a complete heart block. So that's the appropriate intervention. None of the others, honestly, I wouldn't even do any of the others. The others aren't even appropriate for a complete heart block. So A is the only option that's even right. A patient's monitor shows occasional PVCs, 2 to 3 every 5 minutes. So that's really pretty rare. And they are asymptomatic. The nurse should administer IV amiodarone, increase oxygen via nasal cannula, document, continue to monitor, start external pacing. So I would do amiodarone if they had 6 or more in a row or 6 or more in a minute. Okay, 6 or more in a row or 6 or more in a minute, I would do amiodarone or I could do procainamide. But in this case, they're very infrequent, 2 to 3 every 5 minutes, and they're asymptomatic. So what do we do? If they gave me the option to check electrolytes, that's what I would do. But they don't give me that option. Okay, oxygen doesn't do anything. We don't need an external pacemaker. There's not enough to do IV amiodarone. So I'm going to have to document and continue to monitor. Like I said, if it said check electrolytes, I would pick that. That would be a better option than document and continue to monitor. But the right answer is the right answer because of the other answers. I'm really not teaching you how to be a nurse by doing these videos. I'm teaching you how to pass a test, how to answer test questions. A patient suddenly becomes unresponsive. Telemetry shows ventricular fibrillation. The nurse's immediate action is to begin CPR and call for the defibrillator, give IV epinephrine, administer amiodarone, prepare for synchronized cardioversion. So ventricular fibrillation never has a pulse, never. So what they're saying when they say they become unresponsive and the telemetry shows ventricular fibrillation, they're saying this is legit VFib and you can assume they don't have a pulse. If a patient doesn't have a pulse, y'all, they are dead. What do you do if your patient is dead? You start CPR. That's the only thing you can do, and you defib VFib. If it was asystole, I would not defib. You don't defib asystole, you give epinephrine. So if they said becomes unresponsive and the telemetry shows asystole, I would begin CPR and give IV epinephrine. But in this case, they're unresponsive and the telemetry shows VFib. So I'm going to begin CPR and call for defibrillator. A stable patient with SVT, rate 180, complains of palpitations and mild chest discomfort. The nurse should do what? Now, honestly, I wouldn't call patients stable if they had palpitations and mild chest discomfort. What I think this question is saying is if it says stable, it means their blood pressure is stable. Okay, so they've got SVT, supraventricular tachycardia, above the ventricles tachycardia. We don't know really where it's coming from because it's too fast. We've got to slow it down to see what's going on. So their blood pressure is stable, but they are symptomatic. So what should I do for SVT? Perform carotid sinus massage, prepare for synchronized cardioversion, administer IV adenosine per protocol, or increase IV fluids. Synchronized cardioversion is an option, but adenosine is what we do first. So you should remember adenosine is first line treatment for symptomatic SVT, really even asymptomatic SVT. But I don't know that I've ever seen SVT that's at 180 that's not symptomatic. They would at least feel palpitations and they wouldn't feel right. They would definitely not feel right with their heart rate at 180. So A and D, carotid sinus massage, I mean, I suppose you could do that if you're out in the field, but that's not what we do in the hospital if we have drugs available to us, and IV fluids isn't really going to help. A patient's ECG shows a junctional rhythm at 45 beats per minute. He complains of fatigue. The nurse should first assess medications for beta blockers or digoxin, document and observe, prepare for immediate pacing, or push IV epinephrine. So IV epinephrine is only used when we're doing CPR. We're in the middle of a code blue. So, well, epinephrine could be used in a really critically unstable patient who's extremely bradycardic, like in the 20s. I suppose you could use epinephrine, but it's not used for a patient who's like alert and oriented and stuff. We don't generally do that. Immediate pacing, we could do that, but it says, what are you going to do first? So they're fatigued. So if it gave me the option to give atropine, I would give atropine because we give atropine for symptomatic bradycardia. But remember, the right answer is the right answer because of the other answers. So giving atropine is not here. Immediate pacing does not seem to be necessary because they're not unstable. There's no evidence they're unstable. They're symptomatic, but not unstable. Epinephrine is way too aggressive. Should I just document and observe? I don't want to just document and observe because they are symptomatic. If it was 45 and asymptomatic, I could document and observe, but they're symptomatic. So I'm going to go ahead and assess medications for drugs that slow heart rate. That's what I'm going to do. I'm going to assess for drugs that slow heart rate. So what is a junctional rhythm? A junctional rhythm is basically where the AV node is in control. Usually people with a junctional rhythm most of the time we'll end up getting a pacemaker, but it just depends on the patient, depends on how old they are, how aggressive they want to be in managing this, and so forth. So not every person in a junctional rhythm will end up with a pacemaker. We may give them, we may be able to treat them with medications and so forth, or discontinue some medications that may be slowing heart rate. So it just depends, but I would do A. In this case, remember, if atropine was available, I would give that. But the right answer is the right answer because of the other answers. A patient exhibits frequent PVC couplets, that means 2 in a row, and reports chest tightness. Priority nursing intervention is administer oxygen and notify the provider, increase IV fluids, document, continue monitoring, give oral metoprolol. So they're having frequent couplets, 2 in a row, and which doesn't tell me exactly how many in a minute, but if they're frequent, probably 6 or more a minute. I'm going to make that clinical judgment, okay, because I'm expected to look at a scenario, make a clinical judgment. But they're also symptomatic, chest tightness, which means they're not getting enough oxygen to the heart muscle. So remember, these PVCs, often the PVCs indicate a ventricular contraction that is too weak to pump blood out. So if they're having couplets and chest tightness, that means they may have decreased cardiac output if they're not getting enough oxygen to the tissues. So will increasing fluids help that? No. Should I continue to just monitor? No, because they're having chest tightness and frequent PVCs. Give metoprolol slows heart rate. I don't want to do that. Would administering oxygen notify the provider? Absolutely. If I administer oxygen, that's just trying to correct the chest tightness, notifying the healthcare provider saying, what do you want me to do about this? Now, if it said give amiodarone per protocol, or if it said give procainamide per protocol, I would have done that. Well, Sharon, what would I do if they're both there? They're not going to both be there unless it's a SATA question. So you have to understand that the right answer is the right answer because of the other answers. You have to know in general how to treat these rhythms. And then you have to make an evaluation and say, based on the options that they're giving me, which is the best option here, priority intervention, right? The priority nursing intervention. What's the best one here that I have available to me that I should do? A patient's heart rate is 130 with sinus rhythm. So it's a sinus tachycardia. Blood pressure is low. Bolus, I should do what? Bolus 500, administer IV metoprolol, prepare for synchronized cardioversion, encourage deep breathing. So I don't know if the blood pressure is low because the heart rate is high or if the heart rate is high because the blood pressure is low, but it makes more sense that the heart rate is high because the blood pressure is low. So when the blood pressure drops, that decreases tissue perfusion, and the body interprets that as needing more blood, more tissue, no, more oxygen. So it speeds up the heart rate. So it's more likely that the heart rate is high because the blood pressure is low. Now, how can we get blood pressure up? Will deep breathing get it up? No. Will synchronized cardioversion get it up? No, it's a sinus rhythm. Will giving metoprolol get blood pressure up? It would decrease heart rate. But if the heart rate is compensating for the low blood pressure, I don't want to decrease heart rate. Will giving saline, a bolus, fluid bolus, get the blood pressure up? Yes. If you don't know that, generally speaking, the first line treatment for hypotension is fluid bolus, you should know that. Okay, I went through those really fast, y'all. You can always slow it down a little bit. You can watch it again. These are things you need to know for Nclex. The complete heart block, you don't really need to know for Nclex. The Mobitz 1 and Mobitz 2, you don't really need to know for Nclex. But I like to include them sometimes because people, maybe it's interesting to you. Maybe you just want to know how to treat those. Okay. So good luck on Nclex. I get messages from people all the time telling me they passed. Be prepared for 155 questions. Don't give up. If it goes over 85, you're still passing. You hear me? You're still passing if it goes over 85. You're doing well. Good luck. Let me know how you're doing. Thank you for being a part of the Clinic Review family.